Lesson 4, Airway. Our airway is divided into two sections. The upper airway, which consists of the nasal passages, the turbinates in the nose, the oral cavity. Both of these nasal and oral cavities will lead back to the pharynx area, and that's where we'll find the epiglottis. In the larynx, we'll find the vocal cords, and then we'll either have the esophagus or the trachea leading into the lower airway. The glottis consists of the posterior tongue, the epiglottis, which is designed to protect or cover or seal the airway when swallowing, the vocal cords, and then the esophagus. You must know this anatomy if you're going to intubate your patient. Some differences with pediatric patients. Pediatric patients, especially when they're infants, have much larger heads, especially in the occiput area. They also have a larger tongue in relation to the size of their mouth, so the tongue will take up a little bit more space in the mouth, leaving less room. They also have a larger epiglottis. It is not as stiff as it is with adults, so it tends to flop or hang over a little bit more. And the trachea, especially in younger patients, is shorter and comes more to a cone just after the larynx, as opposed to adults, which is more cylindrical. Also, in your younger patients, the right mainstem tends to be straighter than it is with adults, so the potential for a right mainstem intubation is much more frequent with children than it is for adults. If your trauma patient is talking normally, then the airway is open, but you still want to make sure that it is patent and that there's no obstructions. So we're still going to look inside. We're still going to listen for any stridor or abnormal sounds such as gurgling, bubbling, etc. And you want to feel the airway as well. Feel the larynx. Is it secure? Is it straight? Is the trachea straight? We want to make sure that all of these things are good before we declare that the airway is patent. Look for any findings that may consider to be an airway obstruction or pulmonary aspirations like blood, even a little bit of blood. Fractured teeth, those foreign bodies, they may not be blocking the airway now, but if the patient moves or if they become loose and fall, those teeth, which may still be attached, could fall out and become foreign bodies. Look for things like gum. Patients can be chewing gum, and that may become a foreign body obstruction if they get a decrease in mentation or if they suddenly aspirate. Swelling, vomit, subcutaneous emphysema. These can all occlude your airway and make the airway more difficult to access or keep it from being clear. The abnormal sounds like snoring, which most often is the tongue, stridor, which is generally a partial foreign body obstruction or an obstruction, partial obstruction due to swelling of the tissue. Listen for gurgling, and also listen for hoarseness, which may indicate, especially in burns, that the patient has airway swelling in and around the larynx. The abnormal masses in the neck, hematomas, subcutaneous emphysema, and also think about things such as oxygen saturation, carbon dioxide monitoring, which is more of a ventilation breathing issue, but it will really help in determining that your patient is providing enough oxygen to the lungs. So the tongue, like we said, the most common cause of the snoring sound, that will fall back with patients who have decreased mental status. Right? That is generally a sign that they are relaxed, the tissue is relaxed, the tongue is falling back, and that partial obstruction may cause some difficulty with ventilation. You may also have some blood or vomit, some teeth issues like we said earlier. And again, blunt injuries may cause swelling, edema, fractured larynx, subcutaneous emphysema, and hematoma. Penetrating injuries, you may have bleeding into the airway. There's the subcutaneous emphysema again, and also hematoma as well with penetrating. Inhalation injuries can be caused by dry conditions such as heated smoke or fire, heated gas, steam, which tends to be moist, chemicals, which can get into the airway, and not only into the upper airway, but down into the lower airway as well, and cause burns to the lungs and alveoli. Signs and symptoms you would be looking for include swelling, edema, and generally when you have those, you will have some stridor as well, as that happens when that airway starts to swell and partially occlude the airway. Maintain cervical spine immobilization as indicated by the mechanism of injury. And when you're doing airway maneuvers, if you need to keep the cervical spine from moving, remember we're probably going to do a jaw thrust as opposed to the head tilt chin lift maneuver. Your goal is to maintain the patient's airway, that it's patent, allows them to breathe adequately, and allows for good oxygenation and ventilation. If position alone does not work, you may have to move to some adjuncts such as oropharyngeal or nasopharyngeal airway, and if they're not ventilating well at all, you may even have to move to bag valve mask or some sort of advanced airway. You should know all of the things, all of the tools, all of the possibilities that you have at your disposal. It is very important that you anticipate difficulties and think about what your other options are. If your preferred method doesn't work, you may have to move to something else. So we're going to do the basics first, and the complex skills will come as needed. Don't jump right to intubation if you haven't oxygenated and ventilated your patient. Don't just throw a bag valve mask on at first. Put the oropharyngeal airway in and then start ventilating. This all depends on the knowledge and skills of the provider who are doing these things, the situation at the scene, the severity of the patient, any changes that may come about. And again, know your resources, know what you have, know what skills you have, know what resources you have to do it with, and pick the most appropriate thing to do. So as far as opening the airway, the jaw thrust, going to be probably the more common for trauma patients. Also can do the chin lift, but remember, do not do the head tilt chin lift in patients who you suspect with spinal trauma. Oropharyngeal airways and nasopharyngeal airways both have their place, both have their contraindications as well. Do not use the oropharyngeal airway if your patient has an intact gag reflex. Do not use the nasopharyngeal for patients with suspected basilar skull fractures or if they have any Lefort fractures of the face. Your more complex devices include your supraglottic airways, endotracheal intubation, RSI, or rapid sequence induction or intubation using sedatives, hypnotics, etc. to facilitate intubation, and your percutaneous airways or surgical airways, surgical cricothyrotomies. So, chin lift or jaw thrust, first and usually always the way of maneuvering patients with trauma. You're going to maintain cervical spinal mobilization while opening the airway at the same time, keeping your elbows up on the same surface if possible, underneath the chin, and lift. All right, it will lift the tongue or the mandible. It will get the tongue away from the posterior part of the throat. It helps to open up the airway for conscious or unconscious patients. Don't assume that because their eyes are open, they're looking at you and talking to you, that they're able to maintain their airway appropriately. They still may need help. As far as the OPA and NPA go, both are designed to help get the tongue up off the posterior part of the throat and allow air to get by into the pharynx. Make sure you measure them appropriately and size them appropriately. Oropharyngeal airway is measured from the corner of the mouth to the angle of the jaw, the nasal from the nose to the corner of the ear. Make sure you use the right size. Do not use sizes that are too big or too small. They may cause damage or become obstructions. Okay. OPA, like we said, make sure there's no gag reflex. If there is and the patient gags, remove it, use an NPA. The OPA is inserted in a way that is based on the patient's age. If the patient is younger, generally under the age of 8, we do not insert oropharyngeal airways rotated around. We insert them directly or at most 90 degrees and in. If we use a nasopharyngeal airway, then we make sure that we use some type of water-soluble lubricant. Pick the largest nair. If you're not sure which one, insert into the right nair first with the bevel of the NPA flush against the septum. Supraglottic airways rely on a blind insertion technique. You do not need to see where you're putting these devices. They generally are designed to go where they need to, but you don't have to see the epiglottis or the larynx or the trachea or the vocal cords in order to place these. Therefore, they're a little bit easier and more simple to use, not as much training, and it's a little easier to maintain your proficiency in them once you learn the basic technique and how to put them in. Just like any device going into the mouth, though, we want to make sure that the patient does not have an intact gag reflex. The supraglottic airways will occlude the pharynx It will limit regurgitation a little bit, but is not 100%, so your patient can still aspirate. Some of them are available in pediatric sizes as well, so you may see those. And you've got the LMA, which does have pediatric sizes. A version of the LMA called the iGel, that has pediatric sizes as well. We have the Combi tube, which only had 2 sizes, the adult and the small adult size, and is contraindicated for pediatrics. And the King Airway, which does have pediatric sizes also. Endotracheal intubation is a more complex technique. It requires a little bit more training and more proficiency training as well. So a lot more training that goes along with this. It's one thing to learn, but if you haven't done an intubation in a while, it can be more difficult. Requires 2 different pieces of equipment at a minimum, an endotracheal blade and the tube, and those are 1 in each hand, so it requires good coordination between them. And like we said, good training and maintaining proficiency with proper practice as it goes along with that. Some placement options if you're going to do oral intubation. You can do pharmacologically assisted intubation, the use of sedatives, rapid sequence, the use of paralytics, or non-pharmacologic and just intubate the patient. A lot of patients, depending on their status, may respond simply to pharmacologically assisted intubation using sedatives, benzos, etc. Rapid sequence intubation, the use of paralytics is a much more complicated procedure and should require highly skilled personnel for that. Nasal intubation we don't see as much anymore, primarily reserved for medical patients, but can be done in the trauma patient, but as long as there's no facial trauma, head trauma, etc. That's why it's usually reserved more for medical patients. But if you had patients who do need to be intubated who had lower body trauma, the nasal would be an option as well, but probably not a first or best choice. So, which patients are we going to need to intubate it? Well, those who cannot maintain their own airway, those with a decreased level of consciousness, patients who have upper airway burns, because we know that those burns are going to swell and probably at some point impede the airway, or if they already have signs of impeding airway obstruction, those with the stridor, the hoarse voice, those patients, you know they're already swelling up inside and it's going to get worse. So intubate them now before they're completely obstructed so we do not have to surgically crike them. Endotracheal intubation could also be considered when alternate methods of airway management have not worked. If we've tried to ventilate and it's not working. We used a bag valve mask. Maybe we tried a King Airway. Not working or not providing exactly what we need, then we may have to intubate those patients. So before you intubate, consider a couple of things. Number 1, any difficulties or anticipated difficulties. If they're trauma related, especially if there's face or neck trauma, there may be some problems with the anatomy. They may have some pre-existing conditions such as a small mouth. Remember, those children are going to have smaller mouths and the tongue will be bigger inside of it, taking up more room. Any mandible problems, and this may go back to the trauma as well in a displaced mandible or broken mandible or jaw. Patients who have short necks, patients who are obese, these are patients who are going to be difficult to intubate. So before you intubate, also get your backup plan ready and think in your mind, if this does not go well or does not go right, I am going to go to this device, whatever your backup device would be. Be already thinking, this is my backup plan. Don't go in to intubate and it doesn't work and then say, okay, now what do I do? You should already know what your next step is going to be. Have all that equipment ready to go. It doesn't necessarily have to be in your hands, but it has to be in somebody's hands who's ready to use it right away. Not somebody who's got the suction in their hand, but they're standing at the patient's feet. The equipment needs to be ready, located close to where it's going to be used, ready to go. Some other things. Make sure that you've got the proper airway skills. If you haven't intubated somebody in 5 years, you may not be the best person to provide that airway. Right? You need to be proficient at those skills. Right? Pre-oxygenate the patient. If they are breathing on their own, put an on rebreather at a minimum. Not breathing or breathing inadequately, let's ventilate that patient and let's oxygenate them before we intubate. Monitor their oxygen saturation throughout the procedure, and after we intubate, we're going to verify proper tube placement. As far as surgical airways go, again, significant amount of training, retraining, maintaining proficiency, and depending on the equipment that you use, you may have a few parts or many parts in order to complete this procedure. We'll generally use surgical cric or surgical airways for patients who have massive facial trauma. We're unable to visualize, we're unable to see. If we are unable to see or visualize, we could also try some of our other devices. Remember, those blind insertion devices do not need visualization. So again, as part of the procedure, if the intubation didn't work, let's try the non-intubation devices or supraglottic airways, again, King airways, LMAs, etc. Those may function just well for us. If we have an upper airway obstruction that we cannot relieve, we've tried to visualize, we've tried abdominal thrust or CPR, we've tried to visualize and relieve using forceps, McGill forceps or some other device, and we still cannot relieve that obstruction, then we may choose to surgically cric our patient. Or if all intubations and all airway devices are not working and we are unable to intubate or ventilate or provide oxygenation to this patient by any means, then we may surgically cric them. All right, as far as confirmation of placement of the tube, we're going to do many different ways. Although we talk about you need to have at least one mechanical and one physiological method, we are probably going to do every method we can to make sure that the tube is properly placed. Number one, watch that tube pass through the cords. Actually watch the tube and continue to watch it as you push it in. We have a tendency to push the tube in and then we start to look away because we don't watch where it's going. Watch that tube from beginning to end. If you're doing video laryngoscopy, let's watch that screen. Let's watch to make sure that tube is properly placed. Breath sounds, equal clear lung sounds on both sides. May not be clear depending on condition, but at least equal breath sounds on both sides. Should have good chest rise. We should see a change in skin color, although that may not come too quickly depending on the circulatory status and some other issues. But hopefully we get a change in skin color, change in pulse rate. We're also going to do end-tidal CO2 monitoring. We can use esophageal detection devices, etc. Use every tool that you have to make sure that that tube is where it needs to be. And constantly watch it and reassess it. End-tidal CO2 monitoring, good indicator. A good way to monitor your tube and know that it's good. However, don't rely just on that. Every once in a while, listen, look at tube depth, monitor and reassess all those interventions that we do, like we should for all things that we do when we treat the trauma patient. As far as mechanical things go, we talked about the end-tidal CO2, color metric as well, capnometry and capnography. Capnometry is just the number, capnography will give you the waveform picture. Color metric is just a litmus paper that will be either yellow or purple. Purple is what they were when they weren't breathing. The yellow or tan color is what they should be when they have good CO2 release. Again, constantly pay attention to these things to make sure that the tube is where it's at, and constantly listen and reassess tube placement. Definitely reassess before you go into the ER, because you know when you get to the trauma center, the first thing they're going to do if you've intubated your patient is listen to the tube placement. So some of the airway protocols, here's one here. So it talks about the need for airway management. And as you follow through cervical spine intubation, essential skills, obviously clear the airway, manual maneuvers, suction the airway to clear it, and the basin adjuncts. Are they in place? And do we have the advanced skills? Is our SAT doing well? Finish your primary assessment and transport. If we need some advanced skills, then do we have the intubation skills? And we go to the next slide. If we don't really have those intubation skills, but our patient needs some advanced airway, then we could put in a supraglottic airway. All right. Maintain ventilations. Again, you see the FiO2 there, greater than 0.85. Complete the primary assessment and transport. If we have the intubation skills, then let's, again, weigh the risk and benefit of intubation. Should we do oral? Should we do nasal? Again, trauma, nasal is probably not really the first thing we're going to be thinking about. Usually it's oral, but sometimes a possibility. Or should we go with those supraglottic devices? Would that be more successful or easier to do and give us the end result we're looking for, which would be good ventilation? So if we do decide to intubate, was it successful? Yes. If so, let's assist the ventilations, complete a primary assessment and transport. If not, then we'll go to the next slide, which is our difficult airway. All right. So difficult airway. Are we able to ventilate? Yes. Then let's go back to those supraglottic LMAs. And you notice that those are all our fallback devices. If we're having a problem and intubation is not working, we can always fall back to something. Our goal is to make sure the patient is ventilated. Okay? Yes, we would like to intubate because it protects the airway, but if we can't, there's no shame in going back to putting in an LMA or putting in a King airway. Ventilate the patient is the priority. Okay? So if we're not able to ventilate, then we may have to consider doing something else, such as cricothyrotomy, etc., retrograde intubation, etc. Okay, this concludes this section. Please review and do the questions for this section. Thank you.